We will now have our official welcome and webinar etiquette.
Hello, my name is Kasharis, and I welcome you to our Doc Talk series featuring our community experts. As Dr. Bruno Hill said, we welcome you to our actual Doc Talk series featuring the community experts, and we welcome you on behalf of Dr. McCamey. When we are talking about web etiquette, of course, we live in our Zoom world, so please keep your community, your actual Zooms on mute, and we will have a question answer series later. If you have any burning questions, please keep them in the chat, and we will have that question and answer series later. Thank you.
Good evening, everyone. This is Dr. Andrea Boit. I want to introduce Dr. Flood. Dr. Tiffany Flood is a doctorate-prepared advanced practice registered nurse who serves as a graduate clinical educator, track coordinator, and dual certified family and acute care nurse practitioner. With over a decade of clinical nursing experience, she merged invaluable knowledge, experience, and leadership in clinical practice and academia into the APRN role. Service to patients and students is exhibited in her commitment to focusing her skills to increase access to care both domestically and globally by growing the nurse practitioner workforce, expanding the populations within her scope, and global medical mission impact. As a member of the American Association of Nurse Practitioners, Sigma Theta Tau International Honor Society of Nursing, and an HRSA traineeship grant recipient, she considers it a duty and a privilege to practice the converging fields of nursing, medicine, community, and global health.
All right, well, I think that's my cue. Thank you so much. I'm going to get my PowerPoint loaded, and then I will start. All right. So first, I would just want to say thank you for the invitation to be able to come and speak with everyone. I'm kind of used to doing these in front of people, like on a podium presentation. So this is a newer environment for me as well, but I'm really excited. So I'm not going to waste too much time because I can be a little long-winded. So I'm going to go ahead and get started. So my presentation is going to be about minding your website manners. And we're going to have a brief overview on telehealth foundations and its role in health equity. So as I've already been introduced, I would not necessarily consider myself a subject matter expert, but I definitely have some experience in this area and kind of want to share with you what I've learned and how telehealth helps bridge many gaps and what we can do in our role as APRNs to meet the competencies of health equity and move that forward in telehealth. Okay, so I don't have any financial or organizational relationships to disclose. Brief review of the objectives that we're going to accomplish today is that we're going to be able to identify the appropriate use of telehealth delivery methods by understanding foundational concepts of telehealth, characterize the framework of telehealth equity, and translate the advances into the practice of telehealth as a pathway for increased access to healthcare and health equity. So I always like to start off with this slide because where we are now has a lot to do with where we have come from. And so I find that this gives us some context about the development of telehealth and telemedicine over, I mean, this right here starts from 500 BC, but even let's just say the 1920s, which is not too long ago. And so we know that COVID-19 has pushed forward the use of telehealth, has made it more acceptable, and has made it more accessible by CMS allowing it to be a reimbursable service from people's homes, which was not always the case. But if you just take a quick look back of where we have come from NASA being one of the primary pioneers in moving forward telehealth by using like EKG and monitoring, remote medical monitoring, to where we are now, we have made significant strides in the use of telehealth. And many people think it's just getting on a call and just being able to have the convenience of being able to treat patients on the computer or on the phone. But I think that is much more than that. And we even had a brief conversation before this talking about novice nurse practitioners or novice providers wanting to get into telehealth. And kind of starting there, but there's a lot of sensory information, and we'll talk about that, that you kind of lose through the telehealth visit. So remember, we're going to talk a little bit about the foundations first. So this may be very beginner level for some of you all, but as we move forward, we're going to talk a little bit more about where most of us are more likely practicing at. But remember, telehealth is a broad category. You have the live video conferencing, which is the synchronous, the real-time two-way technology that we use pretty much every day in most of our telehealth visits. And then you have the store and forward. These are the e-consults, and this is not used as routinely, but I remember working in a federally qualified health center. This is well before COVID-19, probably in 2017, 2018. And we used a lot of store and forward when we did consults with dermatologists. And this was to actually meet a barrier where patients could not get in to see specialists within 2, 3, 4 months. And we would have e-consults with dermatologists. We would send them pictures through the dermatoscope, and then they would give back our recommendations based on the patient presentation. And so this is another form of telehealth that is very effective at bridging gaps, at getting people in to see specialists and overcoming those transportation barriers or social determinants of health and being able to get them what they need even while they're in primary care. So very important part of telehealth that should not be forgotten. And then there's the remote patient monitoring, where a lot of people think of tele-ICU. So these are the things that are used. These are electronically transmitted medical data, usually patients with chronic conditions. And then this allows patients to have a lot more active role in their treatment, depending on what kind of remote monitoring is being done at home. And then there's mobile health. And so this is probably the little bit more, for lack of a better word, the more lackadaisical approach to telehealth, right? So these are the things that we're able to use through apps and deliver information in those forms using your phone or your tablet to kind of communicate with patients, but it still is a form of delivering healthcare services. And then peripherals. So these are physical attachments. So let's just say you're in a telehealth visit and the patient complains of an earache. You're not really able to look in the patient's ear, but now you can use attachment devices. Not now, you've always been able to, but they're becoming more advanced where you can examine these things through the telehealth visit. So remember that telehealth is a broad category. A lot of services can fall under that. And then there's actually the telemedicine, which is what most of us do in our day-to-day practice. And that's a subcategory of telehealth that refers to the remote delivery of care and clinical services that we provide via either phone, video, or some kind of online connection. So why telehealth? I really think that a lot of people love, like I said, they love telehealth because it allows you to have a convenient lifestyle from the provider perspective, from the patient perspective. They don't have to leave home. They don't have to use up their gas, transportation. But I just want to bring to the forefront that there's a lot more things that go along with telehealth than just convenience. So advancing new models It increases patient engagement. So, of course, overcoming some of those barriers, expanding healthcare access, which we'll talk a little bit later in the second portion of my part of the webinar, and then improving clinical workflow as well, enhancing quality care and increasing practice revenue. So those are some of the other reasons why telehealth can be a preferred delivery method for healthcare. I always like to talk about and address the utilization of telehealth. And this is, it's kind of common sense, maybe no brainer, but it's good to have numbers. And what really pushed telehealth forward is the pandemic, as we all know. And it's really allowed Medicare, the Center for Medicaid Services, CMS, allowing home visits, so people to actually be in their homes, to be reimbursable. And that right there led to about a 63-fold increase in the use of telehealth. So much policy was created behind telehealth. And actually, when I give this in a 60-minute presentation, I have an entire policy update that relates to what telehealth policies were kept federally, which ones were not, which ones were removed, and then how that impacts the way that we can bill for telehealth. But of course, I'm not going to get into that today because we just don't have time. So just looking at this framework for telehealth, especially those of you who are in businesses and who may have a telehealth practice or who may work in a hybrid facility, just kind of remembering all the parts of utilizing the entire framework for using telehealth. It's not just a virtual visit, but it also includes the follow-up, the information that you send the patient after the visit, the way that you deliver the information that we'll talk about, how you can consult between providers, and then that exchanging of medical information either through the patient portal. All of that is within the telehealth framework, not just the virtual visit. So some pearls I like to give for the telemedicine appointment, and this kind of encompasses the minding your website manners, are the kind of 4 pillars to this: identifying the barriers that you or the patient may have, examining the environment, yourself, right? So a lot of self-awareness needs to go into this, and then your technology, of course. So when we're talking about barriers, location can be a huge issue. And I have an example when I have worked for telehealth companies that provide like treatment for opioid use disorder. So of course, there's a lot of barriers for those patients. Oftentimes they can be unhoused or they're living in shelters. And so location is, I mean, I would have some patients who had to drive through McDonald's drive-through or Burger King drive-through just to have access to internet. So location is important, but also your location, where you are in your home, the language that you're using. So the same thing goes whether you're seeing a patient in person or whether you are seeing a patient on telemedicine, right? So being aware of your medical jargon and using language that is consistent with what you may perceive the patient's literacy level to be at. And then also we're going to talk about cognitive and developmental impairments. So that's going to come a little bit later when we talk about how we can address some of those health equity issues and making sure we're being inclusive whenever we have patients with different levels of disability. And then also take into consideration prior missed telehealth visit. Is telehealth even a good option for this patient? I really think people sometimes don't take a moment to think, if this patient just got out of the hospital, they had an MI, they had pericarditis and they're all kind of medicines, do they really need to be seen via telehealth? Oftentimes, those highly acute patients who may be just post-acute, shall I say, who just got discharged from the hospital, or if telehealth is like not a great option for them and they have a history of missed telehealth visits, then having them come into an office or maybe even referring them out to an office visit may be a better option for them. So always be assessing, is telehealth even good way to deliver healthcare for this patient? Then we're going to talk about environment. Having a quiet, private space, try to avoid interruptions. We were just talking about how kids can come into the room. And so sometimes that stuff is unavoidable, but sometimes it is. And as best that you can, trying to avoid that and avoid rooms with windows that prevent backlighting, so that the vision that the patient has of you is not obscured. And then wearing, if you normally wear a white coat, continue to wear that white coat. Wear your name tag, wear your hospital or clinic branded clothing. Silence your phone, your smartwatches. These are things that we practice in person that need to translate in these visits. And so I also want to talk a little bit about our technology. So having all of your applications open and just being ready to document. Some mornings when I would get up and start seeing patients, I have 20 tabs open because I have my portal. I have what I'm communicating the patient with. I'm having my education resources. I have UpToData. So have all your applications up, ready to go, and be ready to document in your EMR system. And then be ready to assist patients with technology issues. Now, if you have a medical assistant who's working, or virtual assistant, whatever that name is for you in your facility, then, though that is where you can delegate those kinds of things. But sometimes I would have to just call the patient. They can't get connected. They're not in a great place. If they're trying to find connection, or maybe they don't know how to get into the portals, especially new patients, just pick up the phone and give them a call. And you have to kind of walk them through, okay, press this here. Did you press this button? That takes a lot of time out of your day. But that really does help conduct a good visit, and really honestly leave a good impression in that you kind of just even care that the patient sees you that day. So being prepared to have backup methods to help patients access the telehealth platform. So just like I mentioned, telephone, email, texting. So when you're gathering information, making sure that you have their phone number, their email, you can text them, because that's just the day and age that we're in. And making sure you have those backup methods and you know where that information is. And then also consider alternate telehealth platforms if the patient cannot access the primary platform. So of course, this has to go through whatever policies you have where you're at. But if you guys using an EMR system is all built in, can you use Zoom with that's HIPAA compliant, right? So there's a version of Zoom that is HIPAA compliant. And that maybe that can be a backup method, and sometimes that may work better for the patient. So considering having those options, and these are just pearls to help your day run a little bit better. All right, so I also want to get into talking a little bit about the provider guided assessment. So kind of jumping around a little bit, and I'm going to play this short 1-minute video. Stanford Medicine, there are 2 physicians there who've done a lot of work about how to translate empathy, how to have effective telehealth visits, and I actually was able to get permission to disseminate some of their information that I'm including here. And whenever we are nurse practitioners, as we gain more experience, our senses, our intuition, our instincts become stronger and stronger based on that experience. But in telehealth, a lot of times you can lose those instincts. And so developing a way that you can still document a physical assessment, I have found novice providers be a little bit challenged with this area, especially if it's not being taught. And so I just want to play a little video, and I won't even play all of it because I know 20 minutes is going to go by really short, but just to give you an idea of what a provider guided physical assessment looks like.
Looks a bit swollen. If you could go wash your hands for 20 seconds, come back. Please bring a tissue. Okay, so 20 seconds have now elapsed. Maya, I'm going to have you take your clean hand with your with one finger in your non-dominant hand, and then gently touch your left eye, the top upper eyelid, so you can see what it feels like. That's a normal eye. The left looks terrific. Okay? Just in terms of gentle pressure, right at the lash line, because that's where I'm seeing most of your swelling. Okay, very good. Now this hand is pretty clean. If you can just wipe it with your tissue, and then let's examine the eyelid on the right. And I'd like you now, your eyelid all
Okay, so really quick video on provider guided assessments, but really what you're doing is you're instructing the patient on how to perform the assessment that you would perform. So presuming that this person here had some eye swelling, some lid swelling, then, she's kind of walking them through how to palpate that upper lid. And then same thing can go for a GI assessment, have them press on their stomach, on their abdomen, and you can have them express, well, how does that feel when you assess, or whenever you press down on that right lower area, right? And so guiding them through that physical assessment, and you can document based on that. So I just wanted to introduce that concept, instead of kind of always doing that inspection, right? That visual exam that we do through telehealth, you can document other parts of the physical exam, more than likely not auscultation, but palpation for sure. You can do that in some of your visits.
One, if you could go.
Right. So in the thoughts or the concept behind minding your website manner, we already talked a little bit about this, but it's really focusing on the interpersonal aspect of patient care that translates standards, professionalism, and ethics in the form of verbal and nonverbal cues that impact patient outcomes. So the key here is that it actually impacts patient outcomes, the way that the patients receive you. And so whenever we are conducting telehealth visits, it can be very easy to just have an approach that is just a little bit more laid back. But I've had some days in telemedicine where, I'm seeing 20 patients and it feels like I was in the office all day, just because cognitively you are really exercising your brain. And if you're being aware of your surroundings, your lighting, camera, your appearance, your verbal and nonverbal communication, emphasizing privacy and confidentiality, and troubleshooting the technology, you're really delivering great service. And that really goes into the whole package that you're delivering to the patient whenever you're treating them. Not just that you know your stuff, but how you present yourself to the patient and how you're conducting yourself on camera, and how that translates to them and how they feel about the care that they receive based on that. So let's get into the second part of this talk, is going to be health equity and telehealth. So I kind of laid some very basic foundational stuff that I'm sure all of you all know, but I'm going to talk, about the health equity and what this entire platform is about. And so in health equity, what we know is that it's an opportunity for everyone to receive health care that they need and deserve, regardless of social and economic status. And providing health equity in telehealth specifically means making changes in digital literacy, technology, and analytics, meaning that we have to make some adjustments to the way that we deliver the healthcare that affects low resource communities, rural communities, people of color, immigrants, people who identify as LGBTQ, people who are under or uninsured, and people who identify themselves as having disabilities. And so giving you a little background on research, there's some good systematic reviews that have been done, scoping reviews that have been done. And here's just a few excerpts from those, showing that and highlighting that substantial telehealth access gaps. They show contributing factors that include not being a native English speaker, needing an interpreter, and having low socioeconomic background. And also showing that augmenting care with telehealth improves outcomes in underrepresented groups, specifically for this study was with diabetes, which is probably, for those of us who practice in primary care, that constitutes many, if not almost all of our patients, if you're seeing adult patients. So while telehealth does have some challenges, it can help improve access and communication, and may increase patient satisfaction for children who require multidisciplinary care for the pediatric feeding disorder. So this was another quote from another study being done. All in all, there is substantial high-level evidence that shows that telehealth has a role to play in health equity. It has a role to play in the way that we deliver healthcare from now until the foreseeable future. So I think solidifying that that is actually a fact and kind of moving forward on from that is where we're going to operate from. And so, talking a little bit about non-discrimination in telehealth, and these are the things where we can, like I had mentioned earlier, right? Providing health equity in telehealth means making changes in digital literacy. So if you don't take anything else away from this presentation, that's going to be your takeaway. That providing health equity in telehealth means making changes in digital literacy, technology, and analytics. So what changes are we going to make? What is our role in this? So let's talk a little bit about people with disabilities. So there are actually legal precedents that have been set where we are responsible for making reasonable modifications for people with disabilities. And this is one group among many, but it is incumbent on the provider to make those reasonable provisions, not upon the patient. So when you think about someone who has an intellectual disability, you always want to consider extending or allowing extra time for the visit and allowing a support person to be present in logging in from a different location from the patient. So that might be a little bit challenging because some of these platforms will not allow you to have a third person log in, especially if it's not something as robust as Zoom that has kind of been just fully developed. But if you're working within an EMR system, that's not always a capability. So making sure you're allowing that support person and scheduling the extra time that's going to be needed for that visit. And then communication disabilities, right? So for the deaf and hard of hearing, sign language interpreter and then real-time captioning should be on and available for the patient. And then when you're thinking about those with blind or visual disabilities, making sure those audio descriptions are made available in real time, ideally for the patient. So written recommendations should also be screen reader compatible. So these are little things that you can take away that will kind of allow you to be able to make those reasonable modifications for people with disabilities. And then in this category of non-discrimination in telehealth, people with limited English proficiency really can the service that they receive can be, I'm trying to find the right word to say, but it can be challenging to meet the need. It's kind of the best way I can put it right now. And so ensuring that if an interpreter, not just having an interpreter available, but an interpreter who's able to speak the medical terms that you're able to speak, same thing we would translate from being in person, but also making sure that the literature is going to be able, that you deliver to them is also going to be consistent with the language that they speak. And so these are some short things. And of course, I have a little bit more to share, but I'm going to try to get through this. I think I only have a couple minutes left. And
actually,
so,
Dr. Flood, we're about 2 minutes over. So if you can try to wrap up, sorry.
Yes, no, thank
Okay.
you for interrupting me. Thank you. So I figured we were. So telehealth in the older adult, nothing new here, but one thing is that you may even want to consider assisting them with their home setup, reviewing technology basics. And one thing to take away here is that maybe for them, video is just not an option. So audio only or phone-based telehealth visits may be the best option for the older adult. So what is our role? Use images for patients with low literacy, make materials accessible in multiple language and formats, allow extra time to address connectivity issues, and then use technology to help with speech recognition and health prediction outcomes. So here are a few resources. Some of these are national resources: American Telemedicine Association, National Consortium of Telehealth Resource Centers is probably the one that I use the most. And these are my references. Thank you very much.
Good evening, everyone. I have the pleasure of introducing Ms. Devyn Nixon. She is a family and cardiovascular nurse practitioner a nurse educator, and a community advocate. She earned her Bachelor's of Science in Nursing at the University of Washington, her Master's of Science at Gonzaga University, and is currently working towards a Doctor of Nursing practice and a Master's in Public Health at Johns Hopkins University. Ms. Nixon practices primarily in cardiology, but also has a private telehealth practice providing access to care for rural and marginalized residents in multiple states. Ms. Nixon was selected for the American Association of Nurse Practitioners 2024 State of Excellence Award for Washington State, which recognizes nurse practitioners who work to increase patients' access to the high-quality care nurse practitioners provide. Devyn Nixon is a founding member of the North Sound Race and Health Equity Alliance, a stakeholder advisor to the Whatcom Racial Equity Commission, president of the Mount Baker Nurse Practitioner Association, a board member for Mount Baker Planned Parenthood, and a student member of Academy Health Committee for Advocacy and Public Policy. When she is not practicing, teaching, or advocating, Ms. Nixon enjoys time with her family, dogs, and just about anything outdoors. Welcome.
Welcome. I'm really excited to share with you all. And kind of echoing Dr. Flood a little bit, really grateful for the opportunity to share a lot of what I've learned along the way with you all this afternoon. So I'll get going here. I have no disclosures. I was asked to talk about leading communities towards racial health equity. And I sat with this for a long time, as I do when I get ready to speak, because I'm really trying to feel into what is the origin of the question. Who is it that would ask this sort of a question? What type of people will be in attendance? And this picture, I love this picture too. This is actually, there was an art contest, and this was done by a teenager in Maryland. This is called A Playground is Just a Small City. But as I was thinking about this, and I'm thinking, gosh, how did I end up with my hand in so many things at so many tables and getting to really truly make an impact in my county and surrounding counties towards racial health equity? And it starts with a vision. The first thing that I would say to anybody who is wanting to be an organizer, wanting to intersect their work as a nurse practitioner with maybe public health, population health, community-based care, is that it starts with a vision. If you can believe it, if you can have faith for something and believe that it is possible, that is the biggest step of all out of everything that I'm going to mention. It starts with a vision, and then when you have your vision and you're like, wow, I wish it could be this way, I think it could be this way. This is when I introduce a process I learned called design thinking. Now, this course is actually available on Coursera for free if you get a free trial and like to do that sort of thing. That's what I did. And I assign this to my students because I find design thinking to be so very helpful. We're really good at generating ideas about what we want things to look like, what we want our communities to look like and to feel like, to be a part of them. But then we have to break it down into smaller steps until we know exactly what is the next best step. So design thinking asks, what is, what if, what wows, and what works? And this is a photo of me last year at the 3rd annual North Sound Race and Health Equity Conference. It started with a vision. And after that vision and asking, okay, what is? This is a question to really get you to do your own community assessment. What's already happening in your community? Who are the powers that be? Who are the funders that fund the kind of work that it is that you're hoping to do? Who are the recipients of grants? for the type of work that you are trying to do, what's already going on out there. So when I began to look at what was going on in my county, Whatcom County, I found, gosh, there's Healthy Whatcom focusing on racial health equity to improve health outcomes for children and families. That's not exactly what I was thinking about and what I was envisioning. It's part of it, but not all of it. And then I saw, okay, there's this Coalition for Anti-Racist Education, okay, but they are focused on school communities and inclusion in the classroom. So again, allies in the work, but not quite doing the work that I was envisioning myself. And I stumbled across a call to action for the Whatcom Racial Equity Commission. Several states have racial equity commissions. You could put your state name into Google and type Racial Equity Commission to see if your state or county has one. But this was when things really started warming up. We had gotten the okay or received a grant to kind of try to build this thing. And by we, I mean my county. I had nothing to do with that, but they put a call out for stakeholders. And I started going to these meetings with other people who were in these rooms, of course, Zoom rooms, and they were lawyers and they were analysts and they were business folk, but there really wasn't any healthcare representation, which is my passion. My passion is to rep for health equity, representation, education, and policy, and I'll get into that in a second. And so I finally found a group, a platform, somewhere to sit, be in community, learn about what questions folks have, what gaps they're trying to close, and how I could be of service in that way. To do that, that was part of what I would call a community assessment. This is another picture from that art challenge by these teenagers. I love this one. It's called Medical Equality. But assessing the community, who's already doing what and where are they doing it? And then if there are already things in place, like the things that I talked about, do they need consultants? Do they need somebody with a healthcare background to consult on the work that they're doing? Is it more of a collaborative opportunity? Could we bring our skill set alongside some of the work that's already being done? Or can we combine our efforts? And that's what we ended up doing. So I live in a community where there's one hospital in the whole county, and there's not a single Black primary care provider in my county. And so this is an issue for me because we know that patient and provider racial concordance, language concordance, gender identity or sexual orientation concordance, patient-provider concordance leads to better outcomes. So for me to be passionate about closing the racial health gap, we know that we need providers, nurses, doctors, nurse practitioners, and the like that look like us. What we found was nobody was really doing anything. So myself and some colleagues got together and we said, what if? What if? What if we had providers who spoke the languages that our patients speak, who have the lived experiences or similar experience to what our patients have? What if we had providers who represent the communities that we serve? And that's when I really kind of hashed out my own personal mission, right? So my vision was, okay, close the racial health gap, right? I mean, not grandiose at all. But when I get down to, okay, Devyn, well, how will we go about doing this? How can I hone all of my passions and foci onto hinging on one mission statement and let everything that I do lend itself to those things? So representation is the work of the practice, and also wanting to raise up more medical providers that represent the communities we serve. Education, I do teach at a university, and I love that because just this year alone, I've got 40 students, and I'm teaching social justice and healthcare, U.S. healthcare policy and leadership, community-based care for vulnerable populations, right? So the more nurses and the more the community that we can educate and educate specifically in the areas of bias, anti-racism, and population-based health. And then finally, what policy stuff applies to this goal of increased representation, and how do we take targeted policies towards universal goals. So the target that we decided as a group, and this we is the North Sound Race and Health Equity Alliance. And just real quick before I go into this picture, we are just providers in the area. We don't all work for the same place. We have a retired physician who's Japanese on the work group. We have a couple primary care providers, myself that are with a different organization, myself and a community-based planner from another organization. And all of us get together and we say, okay, actually providing clinical care, these medical interventions that we're focused on, because that's what our training is, are really downstream interventions. If we really want to see the health of our community improve, we have to work towards strategies to improve community conditions. What kind of strategies were happening in the community to improve community representation in our hospitals and clinics? Well, we couldn't find much. And that's when we implemented the tactic of creating a community alliance to work towards the goal of increasing representation. And this graphic does say a lot, but I really just wanted to highlight, when we're practicing, we're really doing downstream work, and there's nothing wrong with that. That's a good thing. People need clinical care and medical interventions. But if we really want to bring our communities into racial health equity, we have to get higher up on the social needs and improving conditions. So we all recall the drivers of health. Another picture here, this one is Justice holding this balance of folks who appear to have different backgrounds. When you think about the social drivers of health, what are the gaps within the work that's being done? And for me, again, that was a representation gap. Does your skill set lend to any of those gaps? Maybe you're not a nurse practitioner, maybe you're a researcher. Can you do some participatory research in a community that will help make the argument for changing conditions and improving or bring us closer to health equity? What you have to know your skill set and the gaps that you're finding in the work that is being done lend themselves to that. And so again, social determinants that we're all calling social drivers more these days, healthcare access and quality is where I thought, okay, this is a gap. We've got great education systems. We've got jobs that are available to people, but they have to have the proper education. The social and community context is more of the culture and the neighborhood and built environment type of things. What can I actually move the needle on? Well, of course, up here, healthcare access and quality, and focusing on patient-provider concordance, whether that's racial, ethnic, or linguistic. So then we had to think, okay, how do you get a community who's not thinking about something as a problem? We all know that under-resourced communities tend to be putting out fires and tend to be taking care of what's in front of folks to take care of, because capacity is limited when half your day is spent on public transportation, or you're working a job that doesn't pay a living wage, so you have two jobs now. How do you get the buy-in from folks who are distracted and who are the end users, but also the folks who have money to toss around? It's my favorite thing to say these days, because I've seen and witnessed a lot of money being tossed around. But they don't have those community members at the table. So how do you bring people together? Community, hospital administrators, financial folks. And that was the question of what wows. So what me and this group of colleagues did was we decided that we would start doing an annual conference. The purpose of the conference is to educate the community, the communities that we work in, about priority issues within communities of color. So the first year we just laid a foundation. We had a lot of physician speakers who, you know, we laid the foundation of racism in medicine as a thing. It exists. These are the outcomes. This is how things are looking in our neck of the wood. Year two, we found a popular person. This is Dr. Ben Danielson. Everybody out in Washington State where I live knows who Ben Danielson is. He is a pediatrician. He's done a lot of work with young Black kids in Seattle area. And so we asked him to be our keynote speaker. That drew the attention of a lot of people. First of all, he looks like the communities that we're trying to engage. And so there's already that heightened sense of, oh, maybe I'll come see what this guy has to say. But also well respected and very knowledgeable within the medical community. And so the theme that year had to do with healthy environments, and we were comparing and contrasting the experience in nature with Black, Indigenous, and people of color, and then the recreational use of nature that is normalized in white communities. Second year we had, the third year, we had Dr. Shoma Saha, who is the founder of We in the World. And again, popular speaker, brought people together. Once we got those people together, we made an ask. So what works? What works is when you have the right people in the right rooms at the right time, and the folks who have the skill set to move the work along, all together, all excited. Everyone has something that they can give, whether it's time, whether it's spreading the word, whether it's making a donation, whether it's making a connection with a network. And so to date, we've done this just 4 times. Last Saturday was our 4th annual Race and Health Equity Conference. And what we do is we combine the work of educating the communities that are there. About this year, we talked about community of care partnerships and mentorship and allyship, but we had physicians, well, Dr. Paula Houston's a doctor of education, and Dr. Yanya May, both from University of Washington, talk to us about what they have done in a bigger hospital with more resources to address the problems of racial inequities as they relate to health in their neighborhoods. All these sponsors down here that you see, these are all folks, organizations who donate money to keep the conference going. And so when you have these donors, you know, I can name people personally from all of these different organizations, because this work involves a lot of showing up and just being in the room, serving on the board, knowing what grants are coming in, knowing what work there is to be done, and then making sure that your community of focus and other communities are represented. So it's not the same people at the table over and over giving us the same results. The first year when we were talking about doing this work, I said, you know, nothing is more frustrating to me than getting a whole bunch of people in a room together, telling some really sad stories, and we all leave feeling bad. We've all been there, even when it's necessary to tell a story. But it was really important to me to have an ask, to be able to say to people, here's something you can do to turn this around. So we created the North Sound Health Equity Scholarship, and the conference is also our main fundraiser for the scholarship. Scholarship is for Black, Indigenous, and other people of color. pursuing an RN, BSN, ARNP, PA, MD, or DO degree. And we cut checks to our scholars. We don't send it to their school for tuition because they're grown and they know what they need. It might be gas, it might be diapers, who knows? But we also pair them with a mentor, which is really, really important, right? Because we can get our kids into these programs, our community into these programs, and still once they get into the program, they may not understand how to move and what to do, who they need to talk to. How I've had students come up to me and say they were taking a gap year, and the fact of the matter was they just didn't know the next step. And so all of our scholars are paired with a mentor. They get 30 minutes a month that can be phone, Zoom, coffee in person. We work with them to make the best use of their time. And to date, y'all, we have given away almost $80,000 to 17 scholars. We now have 4 people that are practicing in the community. We have a Black psych mental health nurse practitioner male. We have a Black primary care provider, nurse practitioner. We have nurses who speak Ukrainian and Russian, which we've had a huge influx of Ukrainian speaking folks in our community since the war. It's been incredible, but really, again, it all started with a vision. So just to reiterate in summary, if you're looking to lead your community similarly towards health equity, towards racial health equity, you really, really want to get clear on your vision and your mission. Again, remember, my vision was to close the racial health gap. Well, that's a vision, right? But it doesn't give you little pieces of to-dos. So then the mission, getting clear on your mission, which is a breakdown of your vision. So for me, it was, again, representation, education, policy, assess what's already being done, identify what gaps, and are you a consultant? Are you a voice that needs to be at the table in the work that's already being done? Are you a collaborator? Can you come alongside and speak at a conference with, or do a workshop with, or combining efforts? And we do a lot of that in the work that I get to do here in Whatcom County. What wows, this is where we leaned on names that people know. Names that people know, that's what they want to hear and see from, and then we ask them for their money when they show up. And finally, the framework being iterative. So this is a framework that anybody can do. It's not just about where you live. We love conferences. There are so many funders and foundations who have these gatherings and all these opportunities. And if nurses aren't at the table, nurses aren't at the table. But when we do pull up a seat, we have some really important, really impactful knowledge and skills to add to the conversation and improve outcomes. This final picture actually is a crop of a larger picture. This one's actually called The Creation of God by Jeronimo Rosales. And I love this picture because to me, it illustrates, like, it's all right there. Just a little bit of stretch, and together we can make the communities, build the communities that we will thrive in. So thank you for the time. I hope I didn't go over. If I did, I'm giving back whatever's left. Thank you.
Thank you, Dr. Nixon. I know it's 8 o'clock, y'all. If you can just hold on for a few minutes, I would love to do a few Q&A, ask y'all a few questions. Dr. Flood, I'll start with you. I'm just going to back up for a little bit. It was a question from Dr. Nixon, actually, about, do you use any remote monitoring in your practice, like a special stethoscope, otoscope, or even ECG?
And I'm actually going to be off camera. Unfortunately, I had a double booking, but I'm definitely going to finish out this Q&A portion. But I will say, no, I do not currently use remote monitoring. I don't.
Thank you. And then one more question for you, Dr. Flood. In your practice, do you require someone to have an in-person visit prior to having a telehealth visit?
No, I don't. But the thing about that is that you have to have a good intake form, because you need to be aware of kind of why the patient is coming in to see you or wants to see you. So what I'll say for that is, especially having done work in substance use disorders, there's actually, during the pandemic, they were allowances to allow providers to have an initial telehealth visit, and the same kind of goes for psychiatry as well. But now that is not actually true. Those patients actually need to have an in-person visit, or need to have an in-person visit within 6 months, depending on what the reason is that they're coming for, especially if you're being reimbursed by CMS. So I would say with that, if I'm seeing primary care patients, no, I don't require them to have an in-person visit. But if I know that they're coming in for some specialty reason, like opioid use disorder, they want treatment for buprenorphine or something with buprenorphine or something like that, or even psychiatry services, depending on who is being reimbursed, then you want to make sure, or how they're being reimbursed, how you are being reimbursed, shall I say. You want to make sure that they don't require one by the federal regulations. So.
Right.
Thank you for that. Dr. Nixon, no specific questions for you. A lot of kudos, a lot of great work that you're doing. You know, and the fact that, you know, a lot of the comments have been around that this money is going right to them, to the kids, right? And that they receiving mentors. And, you know, Dr. McCamey is all about that mentorship. So she all in here in her comments, right?
That's the one I marked right there.
Yeah.
I will say I saw one comment asking about how the community responded. And so if I could real quick address that.
Yeah, please.
The community responded with an outpouring of support. I do consulting work with different healthcare organizations, and what I find over and over, and I hope this is okay to say, but I find that people are more afraid of appearing racist than they are of being racist. And so they don't want to start a conversation. I hear all the time, I was afraid I would say something wrong, or this work should be led by somebody like yourself, or some. A lot of the work is not going to happen until we show up and say, okay, time to work. This is what we need to do. So they responded very well. Lots of support, outpouring of support that I wasn't sure about. We did get some hate mail our last conference, where somebody really wrote in some ugly words about how this is discrimination and all kinds of backward stuff. But you hear that in this line of work. But I couldn't stay mad with that, because my own CEO, the company I work with, they put up $25,000 matching until May 14th. So they're matching us for another $25K. So I say that because for every naysayer, there's other folks who are just ready and waiting and willing to support the work.
Awesome. Thank you so much.
Thank
I know
you.
we're over, so I'm going to pass it on to the next person to close us out. Thank you both very much for your very engaging presentations.
All right, thank you all. I just want to acknowledge our programming committee, myself, Dr. Brunner Hill, and Dr. Patrice Kingsley, our co-chairs. Dr. Linton is our board liaison. Dr. Marshall Blue with technical support, Dr. Perryman, Dr. Conyers, Dr. Kroll, and Dr. Rose. Thank you all. Our upcoming events, June 20th, Dimensions in Nursing, Cultivating Health Equity Awareness and Barbershop Culture. June 22nd, we have our virtual commencement class of 2024. So if you know any DNPs out there who are graduating, please let them know about our commencement. August 27th, we have our next Doc Talk speaker webinar series. And of course, our conference, October 17th through the 20th, it will be held in Philadelphia. So we're looking forward to everybody joining us there at the conference. And membership is open. We have membership for all. If you are a nursing student, a DNP professional, nursing professional, or affiliate non-nursing professional, you are all welcome here at DNPs of Color. So we look forward to increasing our membership. Please let all know that membership is open. And far as closing remarks, Dr. Kingsley was unable to join us this evening, but I would like to thank you all for joining us. I would say I have learned a lot from both presentations. We hope to make them available to all who are in attendance, and we look forward to seeing you at our next event. And Dr. McCamey, while you are on, I don't know if you have any closing remarks that you would like to say.
I do not, but thank you all for coming out. God bless. Good night.
All right, have a good night. Programming committee, if you can just stay back for about 2 minutes.
I was trying to respond in the text. Let me go. Thanks, y'all. Have a great night.
Don't forget to stop recording.